by making a recording, we always learn, and I always learn from previous experiences right now. So I hope that's okay with everybody. And if we don't like the recording, we'll blow it up. But more importantly, just to share information. Next slide, please. And you mentioned statins. I love statins, but there's more than life beyond statin therapy. Next slide, please. And here's this. This is actually Canadian guidelines from a few years ago, 2016. We can see that magical number aimed for LDL less than 2. That number by the European guidelines is less than 1.0. And to me, if you're a very high risk patient, I would want to have an LDL cholesterol less than 1.0. Next slide, please. And we'll have to prove that to you. We're going to start off with Rachel. And Rachel is 67. She's a smoker. She has a body mass index of 30. Ideal turns out to be somewhere between 20 and 25. She has a blood pressure 120/80. And we learned that getting blood pressure down to 130 from 140 systolic will translate to reduction in cardiovascular risk by about 10% fatal heart disease, 20% myocardial infarction, and 30% congestive heart failure and stroke. So there's nothing magical about 140/80. Lower is better. Unfortunately, having a heart attack in the past increases risk. So this person that's stenting in the past is on a moderate dose of statin, a moderate antihypertensive, taking fish oil capsules, coenzyme Q10, LDL cholesterol 1.3. So that's not too bad, but lower is always better. Lower and longer is better from LDL cholesterol. So without even thinking, I would go to atorvastatin 80 milligrams a day. 40s and 80s are basically the same price. You don't increase bill burden, you get a little extra benefit. Triglycerides are 1.9. So Dr. Young, we were just talking about whether or not 1.9 is a problem or not with low HDL cholesterol. Turns out it's a big problem. And one of the things that augment risk is that don't get old. Once you're over the age of 50, your risk of heart disease mortality goes up. Having heart disease increases your risk. Having diabetes increases your risk. And a triglyceride elevation somewhere about 1.5 to 1.7 increases risk. In fact, having a triglyceride greater than 1.0 increases cardiovascular risk. So at one time, triglycerides were in, they're out, they're back in again. Triglycerides, which we'll talk about, is a marker of risk and maybe a potential target as well. I was surprised to see the hemoglobin A1C only 5.8% on this lady. She is overweight. She's a little bit elderly. She doesn't have diabetes yet, but if she lives long enough, I estimate she will develop diabetes. Now, if we look at her medication profile, I would put her on valsartan HCP 320/25 to get her systolic blood pressure less than 130 if she had no symptoms of postural dizziness. Fish oil capsules is a multi-billion-dollar industry at coenzyme Q10. Do they work or not? Let's sort that out a little bit more. Let's see what we can learn about this. Next slide, please. And so based that we talked about is she at risk? Unfortunately, she is at risk. Now the things that worry about Rachel is that she does have a triglyceride problem. And triglycerides is a marker of risk. Again, somewhere over 1, risk from triglycerides go up, and triglycerides over 1.5, 1.7, 2.0, depending on the people you talk to, increases risk. So I'm going to use 1.5 or so. And in fact, I'm going to make life easy. My ideal lipid parameter is an HDL greater than 1, LDL less than 1, and a triglyceride less than 1. And so let me try to prove why we're doing this. Next slide, please. So if we go back to LDL cholesterol has been around for a long time. I think it was around 1990, the results of the 4S trial came out. And the target LDL cholesterol on simvastatin 20 to 40 milligrams a day was 3.0. And it showed for the first time, if you can get your LDL cholesterol down to 3, you decrease total mortality. Now we go a series of trials. Over 200,000 patients have been randomized to statin therapy. And Jupiter on your far right shows getting LDL cholesterol down to 1.4 derives additional benefit. So we have this progression that lower is better. So we have this target of LDL 2.0 in many of our minds, but as you can see, that's been blown away a number of years ago. So what's really important about LDL, the longer you treat and the lower you treat, the better off you are. Next slide, please. And so should we add things like ezetimibe? Should we add things like PCSK9 drugs? Next slide, please. So to me, the standard became Improve It. Improve It showed that if you got LDL cholesterol down from 1.8 to 1.4, which is really a small change, it provides additional cardiovascular protection. The caveat about Improve It is that 60% of patients stopped therapy during the trial. So compliance was an issue. We now actually have a trial from Japan that shows that if you treat LDL in elderly Japanese males above the age of 75, there's a reduction of cardiovascular events by 25% with just ezetimibe alone. So to me, ezetimibe is a good backup therapy. And so my recommendation is to use a high dose statin and possibly ezetimibe to get the LDL cholesterol to 1.0. Next slide, please. Because then came the PCSK9 drugs. The PCSK9 drugs are phenomenally great drugs, but they're expensive. And with both Praluent and with Repatha, getting LDL cholesterol down lower to 1.4 or to 0.78 shows an additional 20% reduction of cardiovascular events. So this story about getting LDL cholesterol downwards makes sense. And as you can remember, is a 10% reduction of cholesterol over a lifetime translates to reduction of risk by 50%. Or a 50% reduction of LDL cholesterol over 5 years translates to a 50% reduction of risk. So LDL cholesterol reduction is down to 1.0, and there's no lower limit of normal. Lower is always better. All your cells can make its own cholesterol except for mature red cells. So the only downside of very low LDL cholesterol is hemorrhagic stroke that comes and goes. So I think that's a real phenomenon, but controlling blood pressure usually negates that effect. So to me, this is a fantastic story. It only took 30 years to get to this point. Next slide, please. So I think getting LDL cholesterol is important, but if you get LDL cholesterol to 1.0 or less, you have other things to think about. There's smoking. Every time you smoke, 5 minutes of life is gone. Unhealthy lifestyle. Holy cow, is that the pandemic is basically shown us that people are gaining weight, they're not exercising, they're getting more miserable. So I'm getting out there, I'm on my bike. In fact, yesterday I was out, I have this new big fat wheel bike going in the snow, falling all over the place, having a great time trying. We now know, now we're gonna actually show you that a triglyceride elevation is important. Low kidney function, overweight, diabetes, you know about these things. They all increase risk right now. So we have amplifying risk factors that are important, and one of them turns out to be triglycerides. Next slide, please. Lots to talk about, and here's what we think about is that if I got LDL cholesterol to 0, I'm still going to have heart disease. It won't make it all go away, and that's because we have is things like hypertension. We said that getting systolic blood pressure turns out down to 120 decreases risk, but the problem is as you lower blood pressure, people may get dizzy and may tend to fall. So you have to sort of counterbalance that effect with controlling blood pressure and controlling risk. Turns out in diabetes is that diabetes is an amplifier of risk. Tight blood sugar control only translates to a reduction of heart disease by 10 to 15%. So you're better off in diabetes treating hemoglobin A1C for microvascular complications. You get some benefit from heart disease, but it's not outstanding. You get better effects from treating the other risk factors such as blood pressure, diabetes, treatment with LDL lowering drugs, triglyceride lowering drugs. And it turns out that oxidation becomes important and inflammation becomes important. So one of the things Dr. Yellen was talking about, should we use colchicine? Well, the answer is yes, we can now right now because you have 2 randomized controlled trials that show that 0.5 milligrams of colchicine reduces cardiovascular events by about 25%. There's actually data coming out in COVID, it's a protective agent too as well. So part of what I'm doing is you have a CRP elevation greater than 2.0, you're at central adiposity, you have recurrent cardiovascular events. I'm using colchicine 0.5 to 0.6 milligrams a day for cardiovascular protection. And we can also stabilize plaque by preventing oxidation, by stabilizing membrane, decreasing endothelial dysfunction, and improving the plaque composition. Turns out with pure EPA or IPA, as we're going to show about in the Reduce It trial, and this is actually shown in 3 other trials as well, that Gillis, Reduce It, Cherry, and the last trial, the angiographic trial, escaped my name, but we'll come back in a few minutes from now, shows that you have 4 trials, 2 big, large-scale clinical trials and 2 angiographic trials show reduction of plaque volume quickly, within a year to 2 years, and more importantly, decreasing cardiovascular events by 20 to 25%. Next slide, please. So, and that's only with pure EPA. But there's also other emerging risk factors. So Lp(a) is now going to become an important variant right now, because Lp(a) is a modified LDL cholesterol potentially. It's atherogenic and it's thrombogenic. And it turns out that 20% of people in this room have a high Lp(a). I have a high Lp(a) over 600. So does my son. And kind of interesting is that I have lots of heart disease in the family, lots of diabetes in the family, lots of triglycerides in the family. But I managed to lower my triglycerides by losing 30 pounds. I exercise, I watch my diet. I can't change Lp(a) because it's genetically programmed, neither can my son. It increases risk. And his family doctor initially didn't want to start a 20-year-old boy on a low-dose statin therapy. He's on a statin therapy at this point in time, because we learned that lower and longer is better. ApoB and LDL cholesterol we talked about. And HDL cholesterol used to be a targeted therapy, but right now it's probably more low HDL as a marker of risk at this point in time. So lots in the lipid panel to think about. Next slide, please. And if we look at lipid panels, we get this idea of LDL cholesterol being bad. We can actually put cholesterol into, again, in very high-risk patients. So those are people with diabetes over the age of 50, diabetes, cardiovascular disease, people, multiple cardiovascular events. My personal advice to you is to make sure that the LDL cholesterol, if you can, is less than 1 with high-dose statin therapy, as I'm thinking about it. Then we can think about non-HDL. So non-HDL cholesterol certainly includes LDL, it includes Lp(a), but also includes remnant particles in atherosclerosis. And chylomicrons and VLDLs are probably too big to cause atherosclerosis, but these remnant called IDLs do cause heart disease. And they oxidize, they penetrate arteries, and there should be consideration for targets of therapy. Next slide, please. And turns out is that IDL particles are found in triglyceride remnants, and that's why they become important. And at one time, we used to use a lot of fibrate therapy because fibrate therapy was shown to be protective in high triglycerides, low HDL cholesterol. It fell out of favor because if you use fibrate therapy for an LDL problem, it doesn't solve it. It doesn't show any benefit. And now we all learn from genetic studies. So if you were born with variations that lead to high triglycerides, that leads to increased cardiovascular events. So I can say without a shadow of doubt that triglyceride elevation above 1, usually 1.5 to 2, that risk starts to magnify, increases or is a marker for vascular risk. It's a marker for endothelial dysfunction, and they're damaged because they promote atherosclerosis. So we know the LDL story. We're going to look at the triglyceride story. Next slide, please. And again, these are through remnant particles, and they cause coagulation, they cause damage to the vessels. Next slide, please. They're very atherogenic. And again, there's no particle called triglycerides. And I think we got the blue particles, the LDL particles. Now we're going to talk about these remnant triglyceride particles. They are certainly a marker of risk, and you can actually look at the triglycerides for non-HDL cholesterol, which is basically cholesterol minus LDL cholesterol, just to find them right now. I look at particles separately in my mind. And of course, there'll be Lp(a), which will be measured as an LDL particle. It's one that you really have difficulty lowering or conventional therapies, but there are medications in the future to look at that. Next slide, please. Next slide, please. And here's the data with triglycerides. So this basically, if you look at this observation, this is from Copenhagen, and it shows that if you have a triglyceride level of 1 or greater, as it goes above 1 to 2 to 3, the risk of cardiovascular goes up. And it plateaus around 5 to 10, because when your triglycerides are above 10 or 5 or so, what happens is that you have more chylomicrons, or more likely VLDLs. They don't cause atherosclerosis, they'll cause pancreatitis. So first of all, you should be treating triglycerides above 10 to prevent pancreatitis. But triglycerides somewhere between 1.5 to about 4.5 to 5 have remnant particles and increased risk of vascular disease from myocardial infarction, ischemic heart disease, all-cause mortality, and stroke. Next slide, please. What we also learned is that if you get LDL cholesterol down, it's important, but you can see that if you treat LDL cholesterol, if you have a triglyceride here in this population, prove it, if your triglyceride was above 2.25, your risk goes up. So again, triglyceride is certainly a marker for increasing risk. And these are people that were already treated to LDL 1.8 or so. This unmasks another form of particles called remnant triglyceride particles that cause atherosclerosis. Next slide, please. Lots to talk about. And these are the genetic studies as well. What's happened in the last 5 to 10 years is that we're identifying people based on genetic markers, so-called Mendelian randomization. So if your triglycerides were born to be elevated through genetics from ApoC, LPA, lipoprotein lipase deficiency, or any ApoC, ApoC3, these lead to higher triglycerides and increased risk of vascular disease. We're now going to look at targeting these pathways a lot more in the next few years, so more to come in this area. But this just means that if your triglycerides are elevated because of genetic factors, you're increased risk of cardiovascular events. Next slide, please. Now, so Rachel's triglyceride of 1.9. I hope I'm convincing you right now that the triglyceride level above 1.5 to 1.7 increases risk. In fact, triglycerides above 1 increases risk. So having a triglyceride elevation is one of those pillars that increase vascular risk. Next slide, please. So there's no, and here's the data once again. You look at from Canadian data saying that triglyceride increases risk, and it becomes more common, especially in people who adhere to poor lifestyle changes. Next slide, please. The good news, it does respond to lifestyle changes. So we started to add enhancing risk factors. So first is don't get older. And so once you start at the age of 40, usually about 50, your risk goes up. But having family members with things like diabetes. And one of the things is that if a lady has gestational diabetes, she will most likely have diabetes later in life, and it's a risk factor for future heart disease. So gestational diabetes, gestational hypertension, having a big child, all increases risk of future vascular events. So that's actually kind of important to realize that. The other thing too is that, again, people with a triglyceride level, this says 1.7, that's fine. More likely to have hypertension, overweight, metabolic syndrome. We know about smoking. And these all, in looking for end organ damage, renal insufficiency, these are all markers of increased risk. Next slide, please. So it just adds to level of risk. And so Rachel is already at high risk because she had cardiovascular events. She got her LDL cholesterol close to 1, which is wonderful. But she has this high triglyceride. And she has insulin resistance because of central adiposity, high triglycerides, low HDL cholesterol. She doesn't have diabetes yet, but she's on a pathway for diabetes. So this makes me feel nervous. In fact, what I want you to remember, and I'm going to show you this a little bit later, if you have a patient who's had a cardiovascular event over the age of 50, has a triglyceride greater than 1.5, has an close to, so we have, take that back. So you have some cardiovascular events, diabetes number 2, and number 3 has a triglyceride greater than 1.5, in the REDUCE-IT trial, which we'll show you about, that person has an 80% vascular event rate over the next 5 years. And that's a so-called stable patient. Next slide, please. So we have lots to learn and lots to look about that. And that's actually after the LDL cholesterol has been not badly controlled. Next slide, please. So we go back to Rachel again, is that triglyceride of 1.9 is worrisome. Next slide, please. And at one time, we'd use fibrate therapy, and we'll have some further direction about this. I'm still a firm believer that patients who have a triglyceride level between 2 and 5, and HDL less than 0.9, high risk for vascular events, would benefit from fibrate therapy, but we need to look at that more carefully. The trials of fibrate therapy initially were positive many decades ago, but more recent trials were negative. And if you use fibrates to treat LDL cholesterol, there is no proven benefit. In the high triglyceride, low HDL cholesterol population, there may be benefit, but that will be answered in a couple of years, and I'll show you the trial that's underway to look at that right now. Niacin is a drug I haven't used in quite some time, and niacin is a good drug if you don't like somebody. But if you really care for them, it's a very hard drug to use. You have to use over at least gram to 2 grams of flushing niacin to show some value. And it does cause gout, it causes uric acid to go up, it aggravates peptic ulcer disease, and we have better drugs. So I don't use it. When it comes to omega-3s, the only one that you're going to be looking at is derivatives of EPA showing protection effects. And let me show you this a little bit right now. Next slide, please. And so again, the fibrates and niacin is that I don't use niacin, and we can talk about whether or not you should fibrates or not. And if you look at the data of DHA and EPA, let's look at some of the data where we're sitting today, because that's changed dramatically. And let me show you some exciting news. Next slide, please. Turns out, and I'll tell you the answer, IPE is basically a stable form of EPA. So if you look at fish oils, the omega-3s, they come in 3 varieties: EPA, DHA, and alpha-linolic acid. Alpha-linolic acid is the vegetable form. We'll come back to that right now. If you now buy over-the-counter fish oil preparations, unfortunately, they contain a mixture of DHA and EPA. That most of them, or they could be rancid. They have extra products in there, such as saturated fat. They may be contaminants. They're not pure pharmaceutical grade compounds, and they usually don't show any cardiovascular protection. And I'll show you where we are when it comes to that just a sec right now. EPA or IPE is the compound that you want. So right now is that you want IPE at 4,000 milligrams a day, and that shows cardiovascular protection, a reduction in cardiovascular events by 25% in a high-risk population. Next slide, please. In God we trust, everything else needs data. And so over-the-counter fish oil preparations don't work. EPA or IPE works. Next slide, please. And if we actually look at the data, all the consensus guidelines right now switch to, you can use DHA and EPA to lower triglycerides, but it doesn't translate to reduction in cardiovascular events. IPE or VASCEPA decreases cardiovascular events. Let's go to the next slide, please. And this turns out to be the REDUCE-IT trial. Now, I've heard REDUCE-IT so many times, I think everybody knows REDUCE-IT, but let's actually explore REDUCE-IT properly. This is a randomized controlled trial, 8,000 patients, big trial. Placebo, 4,000 patients, IPE, or a form of EPA, 4,000 milligrams a day, 4 capsules a day with complete follow-up or known vital statistics in close to 99% of people, and 90% of people complete the trial. So great follow-up, period of treatment, about 5 years, 4.9 years. So a large randomized controlled trial with very good follow-up. Next slide, please. To get into REDUCE-IT, we talked about is that you had to be high-risk primary prevention. So basically, roughly 70% of people had cardiovascular disease. So they had some form of a heart attack, peripheral vascular disease, and they were over the age of 45 years of age. Unfortunately, we're getting a little bit older, and age increases mortality at cardiovascular events. So don't get old, don't have heart disease, and don't have diabetes. So you can end the trial by having cardiovascular disease, or you're of the age of 50 years of age and diabetes with an additional risk factor. Almost every diabetic in your practice will have an additional risk factor. And they want to ensure that LDL cholesterol was well controlled. So to get in the trial, you need an LDL cholesterol between 1 and 2.5. You're on good dose of statin therapy and ezetimibe. If we were going to do the trial today, if this is the trial I would do, I would make sure that LDL cholesterol was down to less than 1.0. And you had to have a triglyceride elevation between 1.5 and 5.6. So again, high-risk patients by the fact of established heart disease or diabetes, age or the age of 45 to 50, high triglycerides. And you had controlled LDL cholesterol. So if you look at Rachel initially, you'd say not badly treated, but Rachel is still at high vascular risk. Next slide, please. And look at this. The reduces, basically you got 4,000 milligrams of IPE, or basically EPA, translates to reduction of cardiovascular events by 25%. Now, what they're not showing here is about 6 or 7 zeros in front of that p-value. Number needed to treat was around 21. So very effective therapy. You can see the curves start to diverge at about 2 years, and by 5 years, clear benefit. And this basically looks like the first statin trial. So for cholesterol reduction, you need to be on therapy for probably about 2 years. And for 5 years, you show clear benefit reduction of cardiovascular events. And also in these stable patients, event rates were about 22% of the placebo group, 17% on active therapy. Next slide, please. So not insignificant events. And that was time to first event. What we also know is that people have more than one event. These are high-risk patients. So some people have 2 or 3 events. And you can see that it's not just heart attacks. So heart attacks were reduced by 31%, cardiovascular deaths by 20%, strokes by 28%. Next slide, please. And again, this actually reminds me to tell you is that people have more than one event. So this actually, which is really smart, again, in clinical trials are now doing this, is that they're looking at first, second, third, or fourth event. You can see that 900 patients or 900 events, first event, you can see a lot more patients. And some patients even had 4 events. And you can see that that was reduced very favorable by about 30%, all cardiovascular events. Next slide, please. And I think it's really important to look at all total events. Again, we talked about this already. Next slide, please. And so we can see between a 20 to 30% reduction of cardiovascular events. So again, these people were reasonably well treated with statin therapy. So we know that lowering LDL cholesterol, like a good sports franchise, you don't have one-star player. You need more than one-star player. So basically, IPE or EPA and statin therapy has multiple effects. So we talk about decreasing inflammation. So we can see that CRP was lowered by about 20%. Triglycerides were lowered by about 20%. Stabilization of membranes were also taking place. And so LDL cholesterol is important. And it turns out that EPA is also important as well. Next slide, please. So big benefit. Now, evaporate. That was the 4th trial. So basically, we have 4 trials that show reduction of cardiovascular events with pure EPA. 2 angiographic trials. Here's evaporate. Evaporate was a trial that looked at basically, again, Vasipa, 4,000 milligrams of 4 grams of pure EPA. And over a period of basically 18 months, you can see that no matter how you looked at plaque got better. So you can see placebo in the top part progresses, and then on the darker color, it decreases. Now, low attenuation plaque are those plaques that have a lot of lipid core in there. There's lots of inflammation going on. There's cholesterol breakdown. And those are the plaques that are more prone to plaque rupture and atherosclerosis, where a hard calcified plaque was changed a little bit. And those plaques are more stable. So how you look at it shows a benefit. So basically the reduced trial showed that clinical events were decreased by 25 to 30%. This shows that over a period of less than 2 years, the angiogram is getting better. And for each of these trials, Evaporate has a second trial called Cherry, showing the same thing. And Reduce It has a secondary trial called Gillis, showing the exact same thing. So you have 4 clinical trials that show overwhelming benefit with pure EPA or IPE. So IPE is a more stable form of EPA. It's a pharmaceutical grade that's found in Vascepa. Next slide, please. And so 25% of the patients that you and I look after have a triglyceride that meets the entrance criteria of Reduce It, having a triglyceride elevation of 1.5 to 5 range. LDL cholesterol controlled around 1 to about 2 range. Seems to me they all come to my practice. Seems like every second patient has a problem. Now, the good thing about triglyceride, it is amenable to lifestyle changes. LDL cholesterol is amenable to lifestyle changes, but not the same degree. You can lower triglycerides easily in many patients by 40 to 50% if you really adhere to good lifestyle changes that include no alcohol, weight reduction, a good diet that pays attention to glycemic index, and reminds us is that we should be considering 2 fatty fish meals a week as a minimum. The Japanese eat a whole lot more than that and have higher EPA levels than we do in North America. Next slide, please. So looking for those patients are now important. And basically all the guidelines across Canada, North America, Europe have basically had a special recommendation at the results of the Reduce It trial that 4,000 milligrams of EPA or IPE decreases cardiovascular events. And those were studied predominantly in patients who had high triglycerides. In Reduce It, there are some people whose triglycerides are less than 1.5, they derive benefit. And there's also the Gillis trial we'll show a little bit later, showing people with normal triglycerides derive benefit. But basically, to be a purist, triglyceride greater than 1.5, established heart disease or diabetes or the age of 50 years of age shows an overwhelming benefit of IPE or EPA. Next slide, please. And so to me, it's kind of nice to have more than one pathway. Is that getting LDL cholesterol well less than 1, adding things with high dose statin therapy, ezetimibe, and PCSK9 drugs if you can't achieve it, makes sense. And now looking at patients whose triglyceride is greater than 1.5, getting and triglycerides over 1.5 is a marker for cardiovascular risk. It's a marker for remnant particles. In fact, the patient with the highest triglycerides derive more additional benefit from using EPE or IPE. But it's also important to realize that the reduction in triglycerides do not correlate to benefit. And what we're going to talk about is the benefit correlates to the EPA level in the serum. Next slide. And so right now in Canada, you can get Vascepa, which is 4 capsules a day. You should take it with food so you don't burp as much, better absorption rates. The downside of this, as Dr. Young points out, it does increase the risk of atrial fibrillation. It does make you belch a little bit more, but shows reduction of cardiovascular events by 25%. And really, there's no interaction. You eat fish, it doesn't really interact with drug therapy. Taking this with it is not really something to think about. And it will make you bleed a little bit more. So you have to watch about, but it's not serious bleeding complications, more bruising more than anything. Next slide, please. So, so to me, now Rachel starts off with some pillars. She does have heart disease. She does have a triglyceride 1.9, but it was surprising that her hemoglobin A1C was 5.8%. If she had diabetes, does anybody know what her 5-year risk at having a cardiovascular event took place in the Reduce It trial? So this stable patient that you'd see in your office, hasn't been hospitalized, and has an LDL 1.3, has a triglyceride 1.9, let's say she had a hemoglobin C of 7%. Any guesses what her 5-year risk of having a vascular event would be? I was quite surprised. Turns out it's 8%. Wow. And you can lower it down to 50% by adding the or EPA 4,000 milligrams of pure EPA a day pharmaceutical grade. As we talked about before, and we should reiterate, is that over-the-counter fish oil preparations have a mixture of DHA and EPA. They have other contaminants and other fillers from saturated fats. The LDL cholesterol, the DHA and EPA are not pharmaceutical grade, and they're more likely to be oxidized, and they won't work as well. So that's something to think about. Next slide, please. And again, is that having a high triglycerides or diabetes are markers of risk, especially in patients who have cardiovascular events. Next slide. And so we're still on a pathway right now. If you look at raising molecules, right now is the ApoA1 gene can actually, if you infuse it, you can actually raise HDL cholesterol, and clinical trials are looking at that. A number of years ago, there's the Milano population, HDL Milano, was infused into people's coronary arteries to prevent heart disease. It didn't work. It was found in parts of Italy, this gene that gave a high HDL cholesterol was translating to hope to longevity. It didn't work. Now we're going to be talking ApoC3 in triglyceride lowering. Now, the story about fibrate, this is PEMA fibrate, is now being tested in a high triglyceride, low HDL population called PROMIS, similar to reduce it. And it will find out if fibrate therapy will now become part of mainstream medicine again. We'll take a little look at that. There's other fish oil preparation. So if we look at EPA and DHA, OMEMI was a trial that was just presented. It was presented in November 2020 at the American Heart Association, and totally negative. And we'll come back to that just in a sec right now. So it looks like if pure EPA works, and if you add DHA to EPA, it negates the benefit of EPA, or it may contribute to that effect. And so let's move on. We'll talk more about that in some other slides. And so if you get back to Rachel, and we try to say you're at high risk, your bad cholesterol is good, changing habits are challenging, but you know what? What we learned is that if your body mass index is over 25, your complications from COVID go up. Unfortunately, don't get old and don't be overweight. And if you have a body mass index over 30, your mortality is substantially higher with co-infections. And we actually know that having a body mass index between 20 and 25 has less lung infections, exercise less lung infections. Ultra marathons have more lung infections, but exercise and now really thinking about is that aging properly keeps you out of the nursing home. So a plea to think about how to incorporate that. I know it's hard, but working together in some way can make a difference. Next slide, please. And we need to think about this. So how to help people set their priorities. I know everybody's busy. I know it's hard, but you know what? Right now, I'm trying to go outside safely. If you want to come join us at 6 a.m. on Monday and Friday, we're at the Street Oak Stairs, climbing some stairs. You can climb 2 stairs or 10 sets of stairs. And on Tuesdays and Wednesday nights at 7 o'clock, we're climbing the stairs too as well. Either as a group, part of our weight loss group, or part of our mindfulness, meditation, and movement plan as well. So please think about how to work together. And it's been shown that you need a lot of support to make these things impactful, and community support, it makes such a difference right now. And so helping people get better one step at a time makes sense. Next slide, please. So we have 2 ways of thinking about this, is that having some fun again. And so we're having a fun hour every Wednesday, and we tell bad jokes, bad stories, and a little bit of exercise for those who want to. Trying to motivate has always been a challenge, but it's never been more important right now. And we'll keep plugging away at this. I think you know this as much as I do. You probably do a better job at this because getting your right side of the brain and your left side of the brain. So your left side is sort of the academic side, the scientific part, which most of us carry. The right side is that emotional critter. I don't care about information. My emotions take over, and how to blend that together makes sense right now. So to me, is trying to work in that direction and have fun doing it. Next slide, please. So coming back to Rachel, is that would a triglyceride 1.9 lifestyle changes are important. Having 2 fatty fish meals a week is important as well. Dealing with smoking, dealing with blood pressure, I get it. Dealing with anxiety and stress are important. Because it's hard, we have to find a better solution to this, but this is so important. Next slide, please. We have to go down firing rate now. So do the best you can. Again, LDL cholesterol 1.3 is excellent, but getting less than that is even better right now. And that triglyceride 1.9 is an increased risk of cardiovascular event. Smoking, increased risk. High BMI. Ideal blood pressure, 110/70. My target of blood pressure in high-risk patients, and I can get to less than 130 to 140, I'm better off. But so if I can do it safely without falling and dizzy spells, 130 is something I think about. But I know for a lot of older, sicker patients, I can't do that. But getting outside, getting a little breath of fresh air makes such a difference for your mental well-being and your cardiovascular health and your triglyceride. Next slide, please. Turns out alcohol used to be something a good thing. It's a bad thing. There's nothing good about alcohol right now from a health perspective. That's unfortunate. And so we have multiple pillars. Lifestyle changes are really, really important in these groups of patients. And we have good pharmacotherapy. It turns out when your triglycerides are greater than 1.5, high risk, especially in diabetics, we have a very effective therapy with IP or EPA or a formulation you want to pick right now. And unfortunately, there's only one preparation in Canada that's available. It's called Nocebo. Again, we're not going to not going to ignore these other things. Using your dietitians, your friends, next door neighbors are so important. Next slide, please. And so the over-the-counter thing. So I hope that I help you decide that getting an LDL cholesterol less than 1 is really important. But having an LDL cholesterol of 1, you're still at high risk. And the Reduce It trial shows that having a triglyceride elevation greater than 1.5, having diabetes, having cardiovascular disease over the age of 50 years of age, unfortunately increases risk. And that taking 4,000 milligrams of EPA a day, pharmaceutical grade, decreases cardiovascular events by 25%. We should not ignore lifestyle changes, really important. I think I'll pause here for a second and discussion.
Okay, well, thanks very much, Greg, for leading us through all of that. It sort of takes me back. I'm wondering if I'm going to be going back like 25 years to the long lineups again in front of the lab, everybody doing fasting blood work. Because although it's not mentioned anywhere here, I'm sure all of these triglyceride levels are fasting.
Yeah, we should come back to that. It's a good question. So basically, you don't need to do fasting blood work very often anymore. So if your triglyceride level is over 5, then I think you have to go for fasting. If your triglyceride level is less than 5, it's nice to put people in boxes by fasting levels, but you have elevation of remnant particles. So to get into reduce it, you have to be a fasting level. But in reality is that triglycerides respond to diet, lifestyle changes, alcohol, and they're floating between 1.5 to 5. I don't care if they're 2.7 one day or they're 1.9 or 4.5. What I do care is that anything north of, let's say, 1.5 to 2 increases risk. So between that number between 2 and 5, so to me, it's roughly the same remnant particles out there, and I don't think need to be fasted. If they're consistently over 5, then I get to fasting because we have to think about things like pancreatitis. And in that case, fasting is sort of the conventional way of looking at that. we don't spend our life fasting. In fact, you know, brings up intermittent fasting for health right now is that in our weight loss gang right now is that we tried intermittent fasting. And basically what I decided with the group to do right now is that every Sunday after dinner, I fast from 7 o'clock to 7 o'clock tonight. So every week I fast for 24 hours, have a little coffee, a little bit of water, and that's all I do. And there's, you know, the different fasts if you want to, from a 16-hour fast to 24-hour fast and different things of that nature. So one way to control weight is to consider intermittent fasting if you want to do that. And that's what I'm personally doing right now. It took me 61 years to get to my ideal body mass index of less than 25. And that's the support of the group I'm in right now, the people around me, my lovely wife, you know, the change in to more plant-based eating. And so I'm not saying you have to do this. And so I'm a plant-based eater with lots of fish in my diet, and turns out to be one way of doing that. So so the fasting is optional, I think. That's 11 over 5. Good question. Any other thoughts from anybody?
Any other questions, guys? I've got more.
I also have some. Go ahead. Go next question.
Well, what do you do? So let's say you actually put the fear of God into somebody, or fear of a cardiac surgeon into somebody, and you've had them on this medication, then they lose weight. Can you take them off of the SCIPA?
Okay.
If they get down to their.
Let me answer that in a few minutes. We're gonna go off the non-accredited part. It's a great question. I have to show you some slides to answer that. Hold that thought for a little bit later. In fact, let's actually go to the next slide. I'm going to show you some other stuff if I may. So this concludes the accreditation parts. And but since the accreditation part, there's been so much more that's happening, and this is such a fascinating area. I spent hundreds of hours looking into this, and I'm going to show you some stuff here. Really fascinating. Next slide, please. So mention OMEMI. OMEMI is another randomized controlled trial that took older patients after their myocardial infarction and were randomized, next slide please, to basically 2,000 milligrams or thereabouts of a combination of EPA and DHA. So they took 1,000 patients post-myocardial infarction, and they were randomized to basically 2,000 milligrams of a combination of DHA and EPA, pharmaceutical grade. Next slide, please. They were followed for about 2 years, and this trial showed absolutely nothing. It showed no reduction of cardiovascular events whatsoever. And they used high quality grade DHA and EPA. What they did show was a reduction in triglycerides and more atrial fibrillation. So you mentioned reduce, it showed more atrial fibrillation. OMEMI showed more atrial fibrillation as well. Next slide, please. Then the trial called STRENGTH. STRENGTH is a very important trial. STRENGTH is a randomized controlled trial, used a 4,000 milligram cocktail of DHA and EPA in 13,000 patients, very similar to reduce it. So to get into this, you have to have basically cardiovascular disease or high risk for cardiovascular disease with a high triglyceride level. And if you actually look at the dose of EPA, it's 2,000 milligrams of EPA and about just under 1,000 milligrams of DHA. And it was basically a bust. It was stopped because of futility, just under 4 years of therapy. Event rates were 12% and 12.2% in active and on placebo. And now the difference here is that they use corn oil as their placebo, or reduce it, use mineral oil. And we'll come back to that just in a second. But this trial should have been positive if DHA and EPA are both, standard fish oils that are pharmaceutical grade. But you can see that despite using a very good dose of fish oil, it didn't work. Next slide, please. And we have to explain this. And let me take a look at this. So basically in STRENGTH, the baseline fish oil EPA level was 21. In reduced, the baseline was 23. And so what the trial basically showed is that you actually increase the EPA level to basically close to 90 in strength, and you increased it to close to 150 or 144 and reduce it. And what I'm going to show you is that there's a linear relationship between, so an average North American will have an EPA level between 20 to 30. And that if you raise it to 150, and that's what the number one benefit, what we'll show you is that raising EPA levels up to 200 translates to reduction of cardiovascular events. And it was a reduction. Now, if you can look on the far right, is that we use mineral oil and reduce it, and corn oil and strength. So one of the things is the effect of the compound. But the FDA and other organizations who look at this do not feel that really, it may account maybe for 5% of the benefit, but it just didn't translate to that effect. Next slide, please. So if you come back to this data here, again, in strength, EPA level on your far left starts off at 23, goes up to 90. Reduce it starts off at 26 and goes up to around 150 range. Now, the trial we haven't talked about is GILLIS. GILLIS is a trial of 17,000 patients using, again, pure EPA. It had no placebo arm. And so it was done in Japan many years ago. And this showed reduction of cardiovascular events by 20%. Reduce it showed reduction of cardiovascular events by 25%. So maybe 5% of the effect may be the placebo. I don't know. We can argue about that. But we now can show you consistent benefit of pure EPA without placebo. So you have, and this actually showed benefit in patients with triglycerides that were normal. It had a lot of women in this. All these patients were all treated with statin therapy in all these three trials. So again, attention to LDL cholesterol was put in place. And it showed that, the next slide, please, that driving EPA up shows benefit. And if you look at this is actually from Reduce It. You can see that as EPA goes up to around 200, there's a relationship that's almost linear, then becomes plateaus. So in Reduce It, you got to the EPA level around 150 or so, and those that got a higher level showed more benefit, both the primary and second endpoints. Now in Reduce It, you got those patients that had an EPA level that went from about 30 up to basically 90 showed benefit. You did not see it if you go back one slide. If you can go back one slide, Stuart, is that in strength, you didn't see that benefit with rising EPA levels. So the two explanations could be, does DHA negate some of that effect? Is it the placebo? But if you actually look at this, is that you can't explain it by this. GILLIS has no placebo, shows benefit. So to me, the explanation right now is that DHA, and I'll show you why in a sec, negates the benefit of EPA. Next slide, please. So what I'm going to suggest to people is that we need to start measuring EPA levels, because here's what EPA does. EPA is looking at, these are membranes. It stabilizes membranes. It's sort of like the Trump wall, is that Trump tried to make a wall that's porous right now, which is full of DHA. So basically, oxidized LDL cholesterol particles can penetrate that wall very easily, where EPA provides a more stable environment. EPA lowers LDL cholesterol, and where DHA causes LDL cholesterol to go up. EPA, by crystallography, again, shows a stabilization. Both these compounds, EPA and DHA, lower C-reactive protein, lowers triglycerides by the same magnitude. So it wasn't the lowering of the triglyceride that appeared to be benefit. It wasn't lower the CRP. EPA lowers markers of inflammation through a different pathway, and that may benefit. So, and more importantly, EPA prevents oxidation of LDL cholesterol. And DHA in test tube models negates that benefit. So we can see that three potential mechanisms how EPA and DHA are different. EPA provides a more stable membrane, so protects the vessels. EPA prevents oxidation of LDL cholesterol. And oxidized LDL cholesterol or remnant particles cause atherosclerosis, where DHA prevents that from happening. And EPA and DHA both treat inflammation, but EPA treats the different particles of inflammation may be important. So this to me probably explains the benefit. And remember way back when in medical school or whatever, we talked about oxidized LDL cause atherogenesis. So triglyceride remnant particles cause atherosclerosis. The remnant particles, they oxidize very easily. LDL oxidizes more easily. And preventing oxidized LDL cholesterol is important. EPA does that. And EPA negates that benefit. So who would have thought we were going to be at this level right now? But that's what the science has said. Next slide, please. So we've learned a lot over time. Now the question is that we know that DHA is very rich in the brain and in the eyes. And do we need DHA for cognition? So it's less well studied. So basically, I put a pooling of randomized controlled trials that can look at DHA and cognition. And we have 2 negative trials and 2 positive trials, relatively of short duration, small sizes. So it looks like DHA may be good for the brain, but it's bad for the heart. Next slide, please. If you look at the eyes, is that macular degeneration. Unfortunately, there are randomized data sets that DHA are not very good for the eyes at this point in time. So again, these are relatively small trials. And if you remember, kids they're very rich with DHA, and maybe DHA is much more important in early development. Maybe it has some importance in Alzheimer's disease, but it's hard to actually show this in randomized data sets. So we're really learning a lot right now, and we still have a lot more to go right now. But I can clearly say is that EPA in 4 randomized controlled trials, next slide please, shows overwhelming benefit. And this is actually data with DHA and dry eyes. And for dry eyes, over-the-counter fish oil preparations have some modest benefit. One of the things we haven't talked about is omega-6s at this point in time. Those are sort of the vegetable oils. They compete with the pathways for DHA and EPA. And if you have too much in the way of trans fatty acids or too many of the oils, that negate some of that benefit effect. So that's important to have less of the oil preparations and have more of the actual foods and avoid saturated fat, and more importantly, avoid trans fatty acids. Next slide, please. So the world's getting complicated. So, I think we're all, remember one time that hormone replacement therapy was good for the heart. Well, it's bad for the heart, it's good for the bones. So it causes thrombosis, it causes cancer and heart disease and multiple effects. So lowering hemoglobin A1C is good for microvascular complications, but it causes hypoglycemia. ACE, ARB, and tresmin, macrolysine inhibition is good for the heart, but turns out to be bad for potentially too much for potassium levels, we should say. And EPA is really good for the heart. DHA is probably good for the brain and the eyes, but EPA later in life is very cardiovascular protective, and DHA seems to negate that some of that benefit. We took us about 30, 40 years to get here, and we're still evolving right now, but this is exciting information. And who would have thought, next slide, please, that we would be at this point in time. But and then we have the vegetarians of the world that talk about alpha-linolic acid. This gets a little bit confusing. ALA is a vegetable form. They have a weak conversion, less than 5% to DHA and EPA. And these are found things like flaxseed, chia seeds, and things of that nature. So my advice to people is have a diet, if you want to, rich in natural fish oils, and that's basically salmon, herring, sardines. And that I certainly don't say you shouldn't eat, chia seeds and flax seeds and walnuts, but their conversion to the fish forms are quite weak. And the trials that supplemented didn't show overwhelming benefit from the heart at this point in time. So it looks like fish is one of those protective foods. Next slide, please. Next slide, please. And in the Gillis trial, they started off with an EPA level of 90, the starting or the finishing point in strength right now. So to me, diet has changed right now. So I think being plant-based is not a bad thing. More fruits and vegetables, things that are white replaced with green. Eggs are a sort of relatively neutral. Milk may have some effects on prostate cancer. It turns out that calcium supplementation may increase risk of heart disease. So the foods in the bottom, all that processed foods, up to 60% of calories needs to be translated into real whole food. And fatty fish are one of those foods that are part of a healthy diet. And having beans is probably the best best for the planet, best for the environment. And certainly I eat a lot of beans at this stage, and encourage people to go that more and more that route. Next slide, please. So the world has gotten complicated, but basically is that Vascepa is prescription drug right now. It is expensive. It costs just under $10 a day. If you have a private drug plan, you can get the drug right now for about $50 if you have a private drug plan. If you're a cash paying person, you can get the drug at a 20% discount. This is the number you need to call right now. They're in negotiation with the Ontario government for formula access or not. It is an expensive drug, but it does work. It decreases cardiovascular events by about 25%. Next slide, please. It works. And this is not a replacement for diets and lifestyle changes, because this is a meta-analysis omega-3s. It's negative. So 1 gram is negative, 2 grams are negative, at least for cardiovascular health at this stage of the game. There may be some benefit of, in some of the trials, omega-3s show a little bit of positivity, a little bit of negative, overall negative. There may be value in omega-3s if you don't eat fish in your diet. That's vital, but overall it's a pretty negative result. But there's overwhelming benefit in 4 randomized controlled trials with EPA, angiograms, and clinical events. The Japanese use half the dose we use in North America, but they start off with an EPA level of around 90. We start off about 20 to 30. So I'm going to start recommending, next slide please, to think about how to get EPA levels right now. I don't think we're going to talk about statin intolerance right now. Next slide please, because I think I've talked more than I want to right now. Next slide please. But saying that most of statin soreness is a belief system. So my message still is that getting LDL cholesterol down, triglycerides are now very important. We have IPE, or right now in Canada, a derivative EPA that is basically pharmaceutical grade, stable, 4,000 milligrams a day for the average Canadian. If you eat a lot of fish, maybe you can get rid of it, maybe you can down to 2,000 milligrams a day. And learning how to measure EPA levels, because the benefit correlates with the EPA level, the serum level. Next slide, please. So I think we're very excited right now. Again, is that there's so much to offer at this point in time. Can't forget lifestyle changes. Can't forget the LDL cholesterol. And now we have 4 randomized controlled trials that show that pure EPA is a benefit, and that DHA negates a lot of that benefit. You mentioned colchicine is cardiovascular protective, and it is. It lowers cardiovascular events by 25%. Lp(a) present in 20% of the world in our population is a genetic, and it needs to be thought about in cardiovascular events. Next slide, please. So we have lots to say. Right now, this is Life Labs. You can get some sort of scoring system, but I don't know if you get an actual EPA level. I have to look into that a little bit more. Next slide, please. So I'm going to start measuring EPA levels when I can figure out how to do that at this point in time. Next slide, please. And EPA level, DynaCares has a certain test too as well. It's a scoring system, but to me, it's the EPA level that's most important. Next slide, please. So that's going to be evolving. And to me, what I'm saying is that it's hard to do all the things we need to do. I'm very proud of our team for putting together all these lifestyle changes. And please visit I'm great at creating videos with Stuart and others that people don't watch. And I hope you'll find something in there that helps you. And this video will go onto there. And next slide, please. Here are some of the programs. This is Devanshi and Mira have put together a very successful group of individuals that are losing weight. I joined them on Tuesdays, and I'm doing the Shidok stairs, and we're losing weight. We're having fun losing them. They helped me lose 20 pounds. Next slide, please. This is the group right now. It's on Zoom. When we get back to regular, we'll do it the other way around. But some of us are walking on the stairs. Next slide, please. What I'm going to just show you one slide just out of fun is that there's now COVID and Vascepa is being tested. So there's something there in COVID. So this is not ready for prime time. This is just 100 patients that basically has a little bit less cough, your taste returns, a little bit less short of breath. Next slide. So again, this is just tantalizing information. this is a tremendous review article that we can share with you that I found very useful. If you want to look at the world of fish oils, next slide, please. And we're actually going to be cooking on Zoom on batch cooking on Sunday afternoons if you want to at some point in time. Next slide, please. So it's really important to figure out, and we're going across Canada. Again, if I can help in any way, here's our office number, phone number, and more importantly, there's my cell number. If you need to text me or call me, I'm always open to calls right now because we need to work better together right now. We need to have fun again. It's been a tough time for many of us, but I'm having a lot of fun, a lot of frustration, but a lot of fun too as well. And so I'm really excited that the world of triglycerides are back. Triglycerides is a marker of risk. And in high-risk patients, you can lower cardiovascular events by using pure EPA, 4,000 milligrams a day. Has to be pharmaceutical grade. The angiogram gets better, improves, and clinical events are there. So these are relatively stable patients on first presentation, but they're not. They're not, and triglycerides help identify them. Diabetes helps with that as well. So the downside, of course, is cost, atrial fibrillation, and a little bit more bleeding, but overwhelming benefit. Overwhelming benefit. I talk longer than I wanted to, but there's so much to say in this area. And more questions and discussion. Go ahead. What else do you want to say, Joe?
Well, I was just going to open it up to questions, see if anybody had anything to say. I know that I'm going to thank Philip for having us together and hosting everything, getting everything arranged, and HLS Therapeutics for sponsoring everything. It's been very informative. It's a whole new world again. It's like starting with 4S again, you know, just starting all over with a new way to help patients.
I think this is so exciting. There's so much that's changed right now. It is a new beginning. And the thing is, this beginning started few decades ago. We just didn't realize that it was there when the JOES trial was done many years ago. And this is just building on that. And so to me is that, you know, triglycerides were there, they're gone, they're back. And, but more importantly, EPA stabilizes membranes, prevents oxidation of LDL cholesterol. And adding DHA at this point in time seems to negate that effect. And the final chapter is not written. There's more stuff to come right now. And maybe we'll be talking about EPA and COVID and other breaths from now. I don't know, but we'll have to wait and see. I know that losing weight, exercising is good for COVID. It's good for my mental health too as well. And you can't forget lifestyle changes. And again, I want to thank Philip and I have gone back a long time. He's been very supportive over the years. And this is an exciting time. We have more to offer right now. And I know this is kind of a complicated, long story, but it is a long story. And you can see that we're just getting started in this area. Any other thoughts from anybody? So to me is identifying, go ahead, high-risk patients and, you know, age, heart disease, LDL cholesterol, diabetes is a very important amplifier. Diabetes doubles risk. Triglycerides doubles risk as well. So these are important contributing factors, and triglycerides are amenable to lifestyle changes and to alcohol restriction. Also, would Vascepa work without statin therapy? Probably, but hasn't been studied. Would Vascepa or EPA work in normal LDL cholesterol? The answer is that we have some data. The answer is probably yes, but it hasn't been well studied. So where we feel more confidence is in high-risk patients over the age of 50 with heart disease and diabetes, high triglycerides. And if you have diabetes over the age of 50 for 10 years duration or greater, what other risk factors seems to make sense to consider that. When you have that shortness of breath and chest pain, you have to decide, what testing to do. And I think, Joe, I saw one of your patients today that didn't want to take statin. For you, it's not going to take statin for me either. She read all the bad things about that. And
what good is the cost referring it down? You can't make them take it. Who can?
I'm going to wear her down. So so the first line is putting doubt. We're asking her to look at the video on statin debate, and she's a little bit scared right now. But she had that right brain personality where don't confuse me with my facts. My mind's made up. But we're going to try to confuse her a little bit of facts and try to develop a little bit of rapport with her and see if we can do something about that. And by the way, she's having chest pain now, by the way. I'm not sure if I gave her on the phone chest pain today or not, but she was starting to tell me about chest pain, but she didn't tell you before. That's okay. That's what we're here for. We're all here to work together. And I really say this about this, back when we started, we used to talk to each other a lot. We used to, one time there used to be hospital lounges where we met. We used to have our meetings where we met together in restaurants or on whatever. Now we do this by cell phone, by Zoom, and by other mechanisms. But it's still important to communicate. So my door is always open, either for a phone call or a text or whatever. I think it's important to remain that way, more than ever. And I'm grateful for just the opportunity to learn, and I'm learning a lot right now. I've learned so much.
So I think this is a very exciting time right now. One of the things is that I think when you say to a patient, your cholesterol pill may cause muscle soreness, you are killing patients. And I say this is actually an amazing trial called Samson. Next slide, please. And Samson took patients who were intolerant to statin therapy that had stopped within 2 weeks and were randomized, only 60 patients that said, I couldn't take statin therapy. They were randomized to getting 4 bottles, statin, placebo, or empty jars. Next slide, please. And it showed that if you took a statin, you were really sick. If you took placebo, you were really sick. If you didn't take any pills for that month, you felt great. So 90% of the soreness is the act of taking a pill. I urge you at some point in time to look at our video on the statin debate. And it suggests is that if you Google statin soreness, you get over 3 million hits and saying what a bad doctor you are to prescribe statin therapy. So to me, this is one major trial, and we're going to do this placebo trial in patients as time goes on to actually show this. Next slide, please. So is that statins are a good drug. People think they're a bad drug. So my message is still get LDL cholesterol less than 1 in very high-risk patients. That I believe in remnant particles are important. That right now that we have IP showing vascular protective effects at this point in time, and applying many lifestyle changes as much as you can to get patients to work together in combination. I very, very much believe in the power of groups and the power of supports. It is too hard for me to get to a weight of 165 on my own. I need a whole community to do that. I need your help. Next slide, please. And I love exercising. And again, these are the things that we talked about, and I'm really surprised. So DHA may be good for the brain, may be good for the eyes, but it's not good for the heart. You mentioned we start off with Lp(a) is a new marker for heart disease, and you should measure that in people. Colchicine can be utilized for vascular events. EPA is vascular protective. Next slide, please. Diet and lifestyle changes and how to make that so happen. We just put a stuff, if you go to Life Lab, this is what they can do right now. I don't know what, you get some sort of omega-3 score right now. I don't know what that is right now. We just found this out today. We're gonna look at a little bit more. It's $75. Some place in the States you can actually measure that. And this is what to think about at this stage of the game. You can get from, Life Labs and Donacare, they have some sort of fatty acid test at this point in time. Got to find out a little more about that over time, man. I want the serum levels right now at this stage. Next slide, please. We're going to explore that a little bit more. This is a Donacare situation. Next slide, please. How you do it. And to me, we're going to end with, group support, working together in some way. And how we stay connected, how to work together. This is a little thing that we're trying to do. Everybody, you'll love Chad's food diary. You'll love the triglycerides. You'll love the benefits of genetics and all these sorts of things. Hypertension, we just, everybody should have a blood pressure machine. 90% of Canadians will develop hypertension. I'm amazed on how many people just don't measure things. But that's okay, we'll keep trying. Next slide, please. And to me, this is this is Devanshi, who really has been so successful of bringing people together in our weight loss group. Next slide, please. Wonderful young ladies going places. This is our last meeting. Right now I joined the meeting on Zoom, and I'm usually climbing up the stairs. I always take a picture at the end sometimes. Next slide, please, and share the group. And it's a wonderful group. If I can be of any help in any way, I put my cell phone number. You can text me, call me whenever you need to. I'm really proud of our clinic staff and our people here. It's nice to be able to do all your own cardiovascular testing and have a place where our waiting room is supposed to be a learning center. Right now it's virtual at this point in time. I want to thank Phil and his team for allowing us on, Dean for trying to keep me on time, and for everybody for listening in. Let's have some time for questions. It's a fascinating story. It's, you know, and who would have thought?
Thank you, Greg, and yeah, keeping you on time is impossible. You know that. I thank you to Phil too for putting this on, and I will remind everybody that this is accredited, so Phil can provide accreditation to everyone. I think he's going to send an email to all of us. If you don't get an email, please send him one, and he will reply. I'm going to open up to questions because Greg's a cornucopia of information. He knows everything about not only the studies, but the lifestyle stuff. So please, any questions for Dr. Curnew?
Sure, if I could ask a question. Greg, so if you, I acknowledged the Samson study, but if you were going to use coenzyme Q10 to help a patient with myalgias that you were either convinced were related to their statins or whatever, what dose would you suggest? And is there a particular type or formulation you'd suggest?
So I tend to use coenzyme Q10 at basically 200 milligrams a day, and those in gel capsules are better. The best place to get them is at Costco's at this point in time. And so to me is that there's some data that that statins in some people can depress the coenzyme Q10 pathway, and supplementation can make a difference. It's been our experience and people like Cleveland Clinic and others that people who are statin intolerant, 70% of people can take some cocktail of statin therapy and ezetimibe, a combination along with coenzyme Q10 and some way along the way. Part of coenzyme Q10 is the placebo effect, and part of it is probably a real effect. Also, vitamin D. It's been shown that people are more sore, and you know you're a great believer in vitamin D at this point in time. So vitamin D up to 2,000 units a day can help with some of the soreness too, especially as your vitamin D levels is low as well.
So that's 200 milligrams once a day of,
Yeah,
of the Costco brand.
Any cocktail you can get, 200 milligrams total a day, and you can just have them divided doses, you know, depending with level, and you just adjust the dose.
Yeah. Just a small comment. The guy who trained me, Gervais Tuga, who is now head of all global research for Novartis, he used to boast to me that he had the best placebo effect in town. And, you know, we kind of, in a sense, we treat it like it's a dirty word, but like, for example, I found a herbal medicine from Germany called Iberogast that's been used safely for 50 years over there and has multiple randomized controlled trials in non-ulcerative dyspepsia that show it's effective. I've started using it in people with gastroparesis and other problems. You know, if they feel better, they feel better. It has a 50-year track record of safety. The Germans track herbal medicines like we track pharmaceutical medicines. You know, so, I mean, if your patient has less cramps and takes their statin and you save their life, I think that's a good outcome.
Yep, absolutely. And I use the placebo effect every day. So, and it's a very powerful tool. The only problem is that Steve Jobs is dead because he thought fruits and vegetables was going to cure his, pancreatic cancer. You know, he had a very curable form of pancreatic cancer. He had one of the rarer forms, which is multiple endocrine neoplasia that was localized. If he took therapy, he'd be alive today, and we'd have better iPhones and better whatever. Remarkable guy, remarkable book, but he made that mistake. And I think most of us underutilize the placebo effect. Most of us underutilize lifestyle changes. I don't know. Part of my problem is that sometimes I get too overzealous in what I want to do, I get people angry. You know, I try to use the Prochaska model change, but I'm in my action phase and they're pre-contemplation phase, and we butt heads. I don't mean to that, but I just see that too many bad things to happen to good people, and I just try to do the best I can to help as many as I can. And so I have to learn to, cool my jets sometimes. I'm getting better as I get older, but I don't always do it. Absolutely.
There's a question from Dr. Sabuba. When do you order fasting or non-fasting lipids?
Yeah, so it's a great question. So most of the time, I don't care. Fasting, whatever easiest. Right now, if you can get your blood work done any point in time, wonderful. If you have a triglyceride that's consistently greater than 4 or 5, fasting is more of a way of putting people into boxes. It's more stable. So, your triglyceride can fluctuate quite a bit. Your triglyceride can be 5, 6, 7, 8, 10, it can vary quite a bit between fasting and non-fasting. If it's always fasting, it's a more stable form. And you can't measure LDL cholesterol once your triglyceride is greater than 5 or so. So if your triglyceride greater than 5, then fasting is probably the easiest way. I would do that, but less than 5, it doesn't matter to me. And since we measure
Good evening again.
Sorry?
Good evening. I love your
Yeah.
patient-centered approach from your presentation. Thanks again for the excellent presentation. The omega-3 you mentioned, I have some patients, when I listen to them, for example, I have one who came to see me recently, who has been taking omega-3, and he said, since taking it, his back pain has disappeared. So that's why the placebo effect, I think, that was emphasized now. We need to really pay attention to our patients and listen more to them.
Yeah, no, absolutely. If you're taking omega-3s and you're like, I've taken people who have like, dry eyes. And I said, this stuff doesn't work. And now their eyes are dry and they're pain. Like I did them no service whatsoever. And so, if you're taking it because you sleep better, helps your depression, makes you pee, whatever you want to do, it's working for you, I have no qualms about it. My biggest problem is that I'm taking all these supplements, but those pills you give me, doc, I don't want to take those ones. So the ones that make you live long. And so, you had 2 heart attacks, and you rely on the omega-3 supplements, you're not protected. So, and those people taking omega-3s if you like to, but at least take the stuff that works. And if you're going to go into CEPA, you have to stop the omega-3s because the DHA component that may negate some of the benefits or all the benefits. And one of the things we haven't talked about is that the ratio omega-6s to omega-3s and things of that nature as well. One of the things I'm going to explore a lot as much as I can is to get EPA levels in serum. And I want to think of, your brain function and your eye function. And I don't know how to put that into context really well right now. I know for vascular health what to do. So I think this is a fascinating discussion, and I've learned so much already. And it's that I would have never thought that we need to measure EPA levels, but that looks like we're going to have to do that to really serve patients. You don't have to, but is that if you want to get some vascular protective effect, that's what would look like you need to think about. So I'm happy to start everybody on the CEPA and not measure anything, but in my heart, I want to know how much I need to take. So can I eat a lot of fish like in Japan and just take half the amount? Or if, and non-compliance is huge right now, and how to get back to that. So yeah, thank you very much for reminding me of the placebo effect. Thank you.
Any other questions for Dr. Curnew before we close?
Oh, hi. Can I just ask a quick question,
Yeah.
Greg, about the risk of atrial fib? Is that how significant was that with the addition of the IP?
Yeah, so it's actually kind of interesting because right now is that atrial fibrillation starts off mostly as an intermittent process, and it gets worse as time goes on. So I know you can actually decrease the amount of atrial fibrillation by 1/3 by eliminating alcohol, or going from lots of alcohol to almost no alcohol. By losing weight, you make a big difference. Sleep apnea, maybe not. And so then if you have a patient who's like, I have a patient that comes in today that every time they go into atrial fibrillation, their life is ruined. In that circumstance, I will not use Nocebo because their atrial fibrillation controls their life. They've already had 4 ablations, it's not working, and giving anything to make their atrial fibrillation worse is a bad idea. On the other hand, if you're in chronic atrial fibrillation and you're on anticoagulant therapy, I have no qualms about it. That's not going to change anything. It's those intermittent atrial fibrillations that are troubled by this that aren't taking anticoagulant therapy that I would worry about. And so, and it's funny about is that, you know, for some people, 2 beats of extra heartbeats drives you crazy, and other people, they can be in rapid atrial fibrillation and not bat an eyelash. So to me, those symptomatic patients, those patients with intermittent atrial fibrillation that won't take anticoagulants, that I would be most attentive to.
Thank you.
Any other questions? Well, on that, I'd like to thank Dr. Curnew. Amazing talk as usual, Greg. It always makes me think. Philip, thank you for having us. I'm going to go now and have a glass of red wine and a steak, and maybe get a Nocebo sample from Phil, because I gotta live. But thank you. It was fun, everybody.
Thank you, Dr. Zil. Thank you, everyone, for attending, and Dr. Curnew, outstanding. Thank you.
So I'm going to give, you mentioned the book, I forgot about this. So what I'm going to do is that anybody who wants one, just contact Phil, and he'll drop you off one of the books over here. Okay, it'd be a real pleasure to give you a book there. And I challenge you all to do something for 30 days and try something different. And Phil and I have gone back from a long way. Many of us have known each other for a long time, and life has changed over the last 30 years or so. And I think, you know, is that we need to really be more attentive to lifestyle changes more than ever. That we need to do the things well, from blood pressure to cholesterol to making the right diagnosis at the right time. And now we have a new tool, is the world of IPE or APA, or however you want to phrase it, is that it's a new avenue that is taking care of 25% of vascular events. And how it fits into your practice is you have to figure that part out there. And so I'm going to try to find my EPA level and just see where I start right now, what the next step should be. So I haven't quite figured out how to do that yet, but I'm certainly on that pathway. And this will be recorded. Please look back and use it. And we'll see. And I did one previously, and that's already outdated. So I have to take probably that one down, put this one up, and we'll see what the future holds. And it's great seeing everybody, and follow everybody's passion. And I thank everybody. Feel a little bit longer than ever, but what else is new? I'll keep trying.
That's a great way to finish. Thank you.
Thank you.
Thank you.
Thank you so much.
Good night, everybody.
So lots of data, very important data. What you have here is my office card. It has our fax number. You also have my cell phone number. So I certainly do not mind being interrupted. You guys are very quiet. You don't ask enough questions. I have 5,000 questions, and I have 5,000 more things to show you about vascular disease. As we start with is the Harvard says longitudinal study shows that quality relationship. If I can make your life a little bit easier, I will do so. You have my cell number. You can call me, text me. You have our office number. I have a nice little bubble in our place here. We have a beautiful office. We do our own cardiovascular testing. We really promote prevention. 30 Days to a Healthier You is a book I'm very proud with the team and stewards here at my side, and others as well. I can just see so many of our team. I'm very proud of what we accomplished. And if all goes well, I'll retire in another 39 years from now. I wish you all well. I know that's a lot of information, and you'll only remember about 10 to 15%. So that's why we recorded. That's why I can talk so fast. You can slow the speed, you can double the speed, but realize is that the heart disease is a big problem, and that there's so much to say. You took out all my joke slides, which is probably a good thing. And I think I'll pause for a second, open to some questions. Any thoughts from people? And what I'll ask is, Phil, for those who want, if you want to do a 30-day health challenge, we'll be glad to give you one of our books, but I want you to commit yourself to trying to be healthier and make your patients healthier. And if I can help in any small way, be very happy to. I think I'll pause. Any thoughts or questions?
Yes, thank you very much for that very informative presentation, Dr. Curnew. We do have a couple of questions, and again, before we get to them, please also unmute yourself. Let's make a good dialogue and discussion and keep it very open. So there's one again from Joanna, and asking, what if the above patient that we had before had a triglyceride that was actually less than 1.9, or let's say less than what was in the study, which is less than 1.6, let's say? What would you do then to this patient?
So the answer is the data is the data. So if you're a pure trialist, you say no. But to be honest with you, is that I think of this drug working more in people that have metabolic syndrome. So again, triglycerides, overweight, not exercising, eating a bad diet. So for instance, this week I had this patient that won't exercise, won't stop smoking, which is a far too common situation, who's mad at the world and has no good relationships, as I can see. And so it was a very easy decision. Now his triglycerides are around 2, so it was a very easy decision to go on Vascepa. He had some prior insurance. And the company right now has a program for that, and they can tell you about that later. Also, another patient this week who had a very high triglyceride and can't afford any medications, has no coverage. The only medication he's taking is just insulin. So unfortunately, he would not be a candidate to take Vascepa because he can't get it at this point in time without, the government doesn't pay for it at this stage of the game. We'll see what happens over time. So the strict answer is that it's the overweight patient. It's the patient that has the highest triglycerides, low HDL, that derives the most benefit. I do believe it probably works outside of that, but I don't really have enough data to say that. So you're going to have to extrapolate for yourself. I don't think it's unreasonable either way to say yes or no. So if you're a pure trialist, the answer is no, but you can go back to Gillis, saying that those patients with low triglycerides also benefit too as well. So I think we're stuck. And I presented multiple mechanisms of action. If the mechanism is, we know it's related to high EPA levels in the blood, and if EPA is working at all in the vessel wall, then it doesn't matter what the triglyceride level is. But if it's working through remnant particles the way we can't identify yet, or it's related to inflammation, then that's important to know that as well. So I feel a little stuck there. So I'm sort of feel like a little bit of a politician here. I'm dodging a little bit. I don't know what to say. I would certainly treat their LDL cholesterol. That's a more mature science. But this science is very positive as well. And that's just outside the boundaries. So I feel stuck. So maybe on a Monday I'll treat, on a Tuesday I won't. I just don't know what to tell you for sure right now. And maybe I'll know a little bit more after the European, or sorry, the American Heart Association meeting. So I'd love to get back to you in about 2 months from now, and we'll have more data too as well.
And another follow-up question. Would you agree that all diabetics should be on statin and ezetimibe regardless of their lipid levels?
Sure.
Or are there any exceptions to this?
Yeah. So if it's a person you don't want, with determined therapies with patients, so if I can get the LDL cholesterol to less than 1, then I'm happy. And for some people, that will be on a low dose of a statin or no statin therapy. For the vast majority, you will need to be on a high dose statin and probably ezetimibe to get the LDL cholesterol to, around 0.5 or so. The reason I feel easy about statins and ezetimibe, it works. We have good data. What I didn't share with you is that there's a second randomized controlled trial with ezetimibe done in Japan again. It took individuals over the age of 75 years of age in primary prevention, and they gave ezetimibe without statin therapy. And it showed a reduction in older people, 25% reduction in cardiovascular events. In the IMPROVE-IT trial, 40% of patients stopped therapy. Ezetimibe lowers LDL cholesterol between 8 and 25%, on average of about 15%. So it works. It's not a strong agent. It works through blocking absorption of cholesterol in the intestine. through a specific protein molecule. And so if my LDL is less than 1, I'm happy. And I'm happier with 0.5. In very high risk patients, lower is always better. So that's why I look at the LDL cholesterol. And again, the angiographic trials with LDL cholesterol show angiographic regression of LDL less than 1 more consistently. But I also know that LDL cholesterol is not the whole equation, because you can have an LDL cholesterol 0 and still have atherosclerosis or LDL. So it's there's still a lot of events beyond LDL cholesterol as well. So I hope that helps a bit.
Thank you for that. And again, any other questions, please feel free to unmute yourself or write in the text box. But apart from that, this is your chance to ask the expert. So anything you have related to this talk or anything related to cardiology that you need to get clarified, please ask Dr. Curnew. Otherwise, he's going to run away and play tennis. So we want to make sure we have him.
No rush, no rush. I still have a few more patients to.
Yeah. Oh, we have a question here by video.
Hi, I'm Reza. How are you?
Good. How you doing?
Good. Thank you. Thank you very much for the presentation. It was great. There are lots of new things that we usually don't see in a book or in other articles. So that was new and interesting. So what products are in the market that we can add on what other medication that we usually prescribe? Is it prescription? Is it over the counter? And what brand products? So we're not.
So the only form of fish oils that you can prescribe that are a benefit right now in Canada is Vascepa. It's by prescription. It's 4 grams a day. The fish oil preparations that you have currently available are not cardiovascular protective. We have good studies to show that they don't help. Other products that are coming right now is that colchicine, for instance. Colchicine in randomized controlled trials show reduction of cardiovascular events, probably by decreasing inflammation at this stage. LP(a) is a different molecule that is really not lowered by these compounds to any major degree. There's now monoclonal antibodies that are being targeted against that pathway. They're in clinical trials at this stage. One of the things, if you can help people with getting better relationships, just exercising, for every 1 MET in activity, vascular events fall by 10%. That's based on observational data. I don't know about you, is that this COVID-19 crisis has caused people to gain weight. It caused me to lose weight. The reason for that is that inflammation, overweight, that central big tummy, makes your immune system not work as well, and it compresses your lungs. So what we do know, the overall mortality from COVID looks like it's 1%, but the young people that tend to die are overweight individuals. So being fit, losing weight, playing bad tennis. Look, I just did a mini triathlon with 25 people. I finished second to last. I got passed by 13, 14-year-olds, but at least I swam, I ran, and I bicycled. And I'm grateful to be able to exercise my mental health. And so all these sorts of things are important. And people that are just isolating themselves and getting worried, and I understand that, but you know what? Do something and encourage it. I think it's important right now, and lowering weight. So the drugs work extremely well, but the diet and lifestyle changes are so important, and more important than ever before. And this weight business, is that I just worry about people's weight right now. And I'm really impressed that losing 20 pounds plus can put diabetes into remission for 2 to 5 years in individuals as well. So I can't express that enough. And what I can get angry, and I get angry too easily sometimes, is that I don't care if you're successful. I do care if you don't try. So I'm going to do my darndest to help in any way. And I want to form a community with you guys. I want to be available, and I want to have more of these types of meetings on a regular basis and share things. One thing I will say to people is that statin soreness may not be a real disease for 80% of people. And what we often say is, oh, we're going to stop the statin. It's like, it's training when Wayne Gretzky got traded away from Canada to the States, Edmonton has never made it back so far. And so don't trade away a statin unless you absolutely have to do so.
I gave fluvastatin and I think levovastatin to a couple of patients that never be able to tolerate, and they came back and they were quite happy. So keeping them with these, with least, although is not as effective as the others, the newer one, but at least patient can take. So they are happy.
Sure. So what I think to use is Crestor Monday, Wednesday, and Friday. It's a low dose, like 10 or 20 milligrams, and every second day at coenzyme Q10. So basically, and I changed from a water soluble to lipid soluble. I said, you're taking Lipitor, which is lipid soluble. I'm giving you a water soluble vitamin, which is Crestor, Rovastatin. It doesn't penetrate muscles to the same degree. You take coenzyme Q10, this will help you 70% of the time. So Trump has made a career of telling people certain things. So, reality is reality, but we have good science. And there's two parts of the brain. There's the emotional part and there's the science part. So you have to decide what you're going to use and use both as best you can. It's so important right now, and we can do a better job about that. So I appreciate, so don't give up on statins. But also, now we have a therapy that's proven in 2 large randomized trials. And what I didn't show you is all the biochemistry behind it. And I'm still learning. I have to thank Manish and his team. I really enjoyed our conversations, and we're still going to try to figure out mechanisms, and there's so much to learn right now. But this is so exciting. P-value is so big.
Product are in the market that if you want to advise a patient to take for this EPA, IPE, so fish oil, there are so many things. So should we send the patient as an over-the-counter, or as I said?
So unfortunately, the over-counter preparations don't work at this stage. I'm quite intrigued about fish consumption. There's variable results from that. So I'm eating a very high fish. I eat lots of salmon, lots of mackerel, lots of tuna, lots of sardines, and I believe that's important as well. But EPA, the only one that shows science right now is pure EPA, the CEPA at this point in time. The rest don't.
What's the name of that? I didn't take it.
Say that again. I'm sorry.
What's the name of this product that you said?
Oh, the CEPA. So Philip's going to come bring you a book over and tell you about this over here. So it's let me see if I hear. Hold on for a sec.
Dr. Carpillo, we'll get to your question. I see your hand is raised.
I'm trying to find my where it is over here. I'll get that. And I'll go find some in a sec. I'll show you what it looks like. Thank you. Go ahead.
There is a question and unmuted. Craig Carpillo, sorry for mispronouncing if I did.
That's fine. Finnish names get mispronounced all the time.
Well, my favorite hockey player is Solani, so I'm sure Greg Curnew, you know who he is as well.
The question is basically, what about plant-based materials for lowering some of the lipids, such as avocado oil and various others?
Yeah, so great question. And one of the things is that, so basically the omega-3 alpha linolenic acid, plant-based, and that comes from flax and from canola. Way back when, the Beyond interim trial showed that you can decrease cardiovascular events in a small series. Can you find me some of the super around somewhere around the box over here somewhere? Maybe it will be here too as well. It showed a protective effect. There was a second trial of about 4,000 patients that showed a trend to benefit, but not a clear benefit with a vegetable form. Remember that ALA, vegetable form of omega-3, has only a weak conversion of maybe less than 2 to 5% to EPA and DHA, but it may have some protective effects. There was a trial done in Spain where people were randomized to extra virgin olive oil, 10,000 patients, or to basically walnuts, hazelnuts, or almonds, and it showed a reduction of cardiovascular events, basically non-fatal. So there is some weaker data right now, and what I'm learning right now is I'm more eating the fruits and vegetables than I am of too many supplements right now, because there's a lot of good marketing, but not enough good science right now. So the science for what you're saying is not as strong as we'd like, but there's some hints right now. So I'm eating a lot of walnuts. I'm eating a lot of almonds, and I think that's lots of flax. And I'm trying to avoid oils, because oil by themselves are rich in calories, and I'm just always eating too much. So there's some data extra virgin olive oil so we don't have a strong data set, and diet's hard to analyze because there's so many variables, and compliance with diet is often so poor. So a long answer is that so hazelnuts, walnuts, almonds, extra virgin olive oil shows something there in that circumstance, and you can add some flax to that too as well. Those are the oils that show the benefit at this stage.
And basically, if the patient were getting those oils from the food itself, eating avocados or eating greens, fruits, whatever, and the nuts, they probably are getting their protein too.
Yeah, so to me, one of the things is that about 3 years ago, I started a bet. We bet $500 to the charity of your choice if someone said I couldn't be a vegetarian. So I became a vegetarian a few years ago, except for fish. And on Thanksgiving, I'll have turkey. But basically, I become predominantly a plant-based eater. Number one, it's good for the animals. Number two, it's good for the planet. And the best source of protein at this point in time for everybody is in beans. And so the only problem with the beans is the gas production can be a problem sometimes. So, but saying that is that I feel really good about that. The only thing is I haven't been friendly to fish. I eat a lot of fish, so I'm a hypocrite when it comes to that point in time, and because I think fish is of value to you. What the Vascepa looks like over here, I'm gonna show you what some of these capsules look like. These are 1 gram capsules each at this point in time. They go down nicely. They don't taste badly either. I could swallow. I need to get some water somewhere, but can you just find some water? You don't really have a bad taste to them. So, so by taking this for the next 5 years, I will lower my risk of vascular events by about 25%. And the only thing I'm using is a plastic bottle, which I don't like to do. And there we go. So, so to me, I chewed the capsules. I didn't really do a good job at crushing. I should have just swallowed them. So I think we had just so much to learn and so much to do better at this point in time. So I hope that answers your question a little bit.
Yes, thank you. I agree with a number of the things you're saying there. I cringe at the fact that this med increases atrial fib, because we see a much greater incidence in atrial fib in our, baby boomer population.
So what's happened to atrial fibrillation is that the trial showed that in patients who have intermittent atrial fibrillation, it increased it slightly. So it really didn't cause a whole lot of new cases of atrial fibrillation, those are existing right now. So we now have pretty good data that if you have atrial fibrillation, losing 20 pounds is of huge importance, and no alcohol
That's right.
will lower your risk of atrial fibrillation by 20%. you can over-exercise in some of the, the triathlons. So I'm a fake triathloner. I just do these mini triathlons. That means I can finish last anywhere. So I'm a bad tennis player. And if you know my hockey skills, I make everybody look good, especially the other team, because I pass the puck to the wrong players. But I really enjoy all the sports and things of that nature. Is that atrial fibrillation become a bigger problem? But the biggest problem we face in North America is diabetes and obesity. Is actually tripled since I started practicing, and so we have to do something about that. So that's why I hope that book helps a little bit, and our webinars and our get-togethers and working together. And I say this with all sincerity: if I can help in any way, I think it's important to make sure it's safe for people to exercise, and I think it's important to give people good information. So that's the best we can do it. And so I share your concerns about atrial fibrillation, but that's not a reason to not use Vascepa for most of the time. But I hear your point. I'm not concerned about that. I just worry about, so I really work hard those 20 pounds. And if I can do it, you can do it. So can the patients, and we can do it together. One of the things we started, we have something called the Weight Loss Club. They meet on Zoom once a week, and we have our health coaches that will love you, beat you, do whatever it takes to help you lose weight if that's what you need. And I got the support of so many people to help me keep my weight down, from my wife, my family, all my students, and so it takes the whole community to be healthy, and we need to work together in some ways.
Well, thank you. Appreciate your answers.
Yes, thank you so much, Dr. Curnew, for being so honest and vulnerable too, and letting us into a little bit of your life and your passions. Again, we still have a lot of people on, so thank you for staying on. If you have any questions, again, this is your opportunity to ask the expert, and if you want to see him take Vascepa or any other drugs that you have questions about, please ask away, because he's here for you, and this is something very important and dear to his heart. And again, I thank you for everyone's time. Any other questions, comments? There was a question, Dr. Curnew, more related to the slides, and if you're posting this on a YouTube channel, like how can people access this again? Is that something that you would like them to have, a PDF version?
If everybody likes, we'll certainly we'll get you all the slides, make a PDF. You've recorded this event, so what we'll do, if you'd like, is that we'll post this on our website, or not a website, we'll post it on our YouTube channel. Right now, our website is broken. We have some fatal error we can't fix right now. So I love computers, but I'm not as good as I want to be. So we're working to fix that problem. But our YouTube channel is something that's working right now, and so. We'll post that on our YouTube channel, and I'll get Philip and others as team as well to get copies of that. So anything that I have shared today, be glad to give you all that information and share that with you. Does anybody want to take a 30 days to healthy you challenge with us and see if you can be healthier than me for the next 30 days? We can wait till after Thanksgiving.
That's probably the best time, right before Christmas. So without further ado, it is the 9 o'clock mark, so 2 hours. Very, very informative. I want to thank you again, Dr. Curnew especially, and obviously everyone who has attended this. Please get in touch with Philip as well. I think he left his phone number and email, and those that deal with Graham as well, please get in touch with them. I'm the medical science liaison that can help answer any other questions if Dr. Curnew doesn't pick up his phone because he gave his cell phone number, but I'm there as well. So please reach out to any one of us. And again, thank you very much for joining, and thank you, Dr. Curnew. A very special thank you from us.
Well, thank you for the opportunity. And what I'll say is that I'd like to get together any time that people want to in a different format. There's so much to learn and so much to share. There's so much that is changing right now, and I'm curious to see what's going to happen at the American Heart Meeting. The European Cardiology Meeting just came out. We're always advancing, but you know, people say you need 2 large randomized controlled trials. We have 2 large randomized controlled trials that show that EPA, pure pharmaceutical grade, decreases cardiovascular events the order of 25%. It works. The downside is, you mentioned bleeding and atrial fibrillation. The cost factor is something that needs to be considered. But you know, we have such effective therapy, and if we just stop at an LDL cholesterol of 2, we ignore so much more cardiovascular events. So from going from 2 down to 1, you decrease cardiovascular events by additional 20% or so. By treatment of remnant particles, high triglycerides with EPA, you decrease cardiovascular events by 25%. And the mechanisms are multiple, from inflammation to triglycerides. And more importantly, it looks like the effect is directly on the vessel wall, totally independent of triglycerides, and probably possibly totally independent of a C-reactive protein. I can't say that with confidence because this drug does a lot of things well, and what's the exact mechanism we're still learning, but it works. And I want to thank everybody for their participation. I've known Phil for a long time, and Nisha, we have lots of questions to explore. And the drug is available in Canada, so it's been available. When did it become to Canada? When was the drug launched in Canada? Now it's
end of February, around the 25th or so, February, or 22nd, I should say. So it's been available in Canada, and it's something that you can get at any pharmacy with a prescription. So it is, like we said, a prescription drug. It's not over the counter. You will need a prescription.
And the problem is trying to launch a drug during a pandemic. It gets drowned out. But this is where we are, and this is where we're going. And one question to remember is that this does decrease inflammation, and so the question of what does it do to COVID is a great question. The answer is, well, nobody knows. The trials have looked at things like pneumonias, infections, and things of that nature. There's no higher incidence of this. Colchicine is now being tested in COVID, but in the non-COVID patients with acute coronary syndromes, it does decrease. So colchicine low dose, 0.6 milligrams, 0.5 milligrams, does decrease cardiovascular events by 25%. Mortality does go in the wrong direction, where mortality goes in the right direction with this preparation. So we still have so much to learn, and an exciting time. So I want to just say the drug works. It's effective. It has multiple mechanisms of action. The most important, we'll still learn. It correlates to high levels in the bloodstream. And so there's where we are today, and we'll have a lot more to say as time goes on. So I feel really privileged to be around for 30-something years, and I have another 40 years to go if all goes well. So, but it doesn't stop us from learning, and it's an exciting time. So I want to thank everybody for coming out tonight, and I want to thank the crew here for putting this all together. You can only you're only as good as the people around you, and thank you so much, Manish and others, and Philip, for all your support. So thank you so much, everybody. And if I can help, you have my number, and we'll talk to you later. And have a great night, everybody.
Thank you very much. And this will conclude our event tonight, and we'll see you on the next one. So thank you again. Take care.
Bye-bye now.